Hello everyone, welcome to my video channel. Today I am going to cover regarding tenodesis. I will starting off with an introduction and definition. The indication for tenodesis. 1 is to correct the deformity. This include A. Hallux varus correction, B. Correction of all mallet finger, C. Swan neck deformity in cerebral palsy. Number 2, reconstructive procedure for paralytic disorders of extremities. Number 3, for stabilization of joints. Number 4, other indications for tenodesis. The disclaimer is the same in all my videos. Thank you. Now let's begin. The word tenodesis in Greek in origin and derived from two words, tenon, which means tendon, and desis, which is binding or to bind. The literal meaning translates as suture or surgical fixation of the end of a tendon to the bone or some other structure. The indication for tenodesis include 1. To correct deformity. 2. For reconstructive procedure for paralytic disorder of extremities. Number 3. To stabilize the joints. And 4. Other indications of tenodesis. Tenodesis is broadly comes under two categories. As a diagnostic sign or test or a physiological effect and a surgical procedure to fix or bind tendon to the bone. The tenodesis effect is a normal physiological process whereby the joint motion, proximal joint, causes a synchronous movement on the neighboring joints. This tenodesis principle can be used as a clinical test in the examination of the hand. Typically, due to the tenodesis effect, passive wrist flexion causes all fingers to go into extension. And with wrist extension, all fingers undergo flexion. However, in flexor tendon injuries to the hand, the tenodesis effect is impaired. Hand surgeons use this same principle to gauge the accuracy of tension intraoperatively during tendon transfers and repairs. This picture illustrates the tenodesis effect, whereby during wrist extension, all the fingers will go into flexion and vice versa. Indication for tenodesis. 1. Deformity correction. Example in A. Hallux varus correction by doing an extensor hallucis brevis EHB tenodesis. The distal part of the tendon is resected, pass deep to the transverse metacarpal ligaments from distal to proximal through a hole drill. Bone tunneling done. It corrects the deformity. As illustrated, the figure shows a passing of a tendon through a bone tunnel and securing the tendon to the medial aspect of the first metatarsal bone. B. Correction of all mallet finger by using a palmaris longus tenodesis. It reconstructs the oblique retinacular ligament to correct the swan neck deformity. This picture illustrates the palmaris longus tenodesis with immobilization using a K-wire. C. For correction of swan neck deformity in a cerebral palsy patient. It is an infrequent findings in CP patient. it is caused by intrinsic spasticity. The problem is it is quite disabling. Secondary ligamentous and capsular relaxation at the proximal interphalangeal joint PIPJ causes this joint to hyperextend. Flexor digitorum superficialis FDS tenodesis is done to prevent the proximal interphalangeal joint hyperextension. As covered previously, the illustration shows the causes of the formation of the swan neck deformity due to volar proximal interphalangeal joint synovitis and volar metacarpophalangeal joint synovitis. Okay, everyone? For D, deformity correction in calcaneovagus deformity. Dynamic calcaneovagus deformity of the foot usually occurs in patients post-polio residual paralysis. Achilles tendon plication and transfer of peroneus longus tendon to Achilles tendon can be done. Tendon transfers are indicated when dynamic muscle imbalance results in a deformity that interferes with ambulation or function of the extremities. E for pes calcaneus or calcaneal foot. It is one of the most severe types of foot deformities and is characterized by the presence of a fixed position of foot extension without active flexion. In most cases, the development of this deformity is due to the lesion of the long flexors of the foot, primarily the gastrocnemius muscle, due to various diseases of the nervous system. This picture illustrates the pes calcaneus, that means fixed position of the foot extension without active flexion. The main pathogenesis of the calcaneal foot is paralysis of the posterior group of the tibial muscles while maintaining the function of the anterior and lateral muscle groups. The tendon muscular transposition were used when the functionality of the muscles of the tibial, lateral or anterior surface is about 4 to 5 points or the power of M5. The long peroneal and anterior tibial muscle were preferred. With the complete loss of the tibial muscle function, tenodesis by westing of the Achilles tendon is performed. Indication for tenodesis number 2. In paralytic disorders, example A, in intrinsic paralysis of the hand. Example in Fowler's tenodesis. It is a cross-dynamic tenodesis where the tendon traverses along both the dorsal and palmar plane of the axis of rotation of adjacent joints. The tendon graft is substituted for finger intrinsics. Fowler's wrist tenodesis uses a tendon graft sutured proximally to the extensor retinaculum. Hence, wrist extension activates the metacarpophalangeal joint flexion. B. Restore key pinch in tetraplegic. By using a Moberg key grip procedure, the flexor pollicis longus FPL tendon tenos to the distal radius. A1 pulley release is done to increase the torque. Percutaneous pin fixation done of the interphalangeal joint of the thumb. This picture summarizes the Moberg key grip procedure. There is a tenodesis of the flexor pollicis longus to the distal radius. with A1 pulley release and joint fixation with K-wire. When there is an active wrist extension, the flexion of the proximal interphalangeal joint occurs. Understood, everyone? C. Irreparable damage to the flexor digitorum profundus, FDP. There is a cadaveric study done by Tamil Prish et al. 2014, whereby the flexor digitorum profundus tendon was transected 1 cm proximal to its insertion to stimulate an isolated zone 1 laceration. The injury was reconstructed using a palmaris longus tendon graft to create a mechanical linkage between the interphalangeal joint, which restored coordinated interphalangeal joint flexion. The clinical relevance of this study. There is a potential use of this tenodesis, but further investigation of the outcome and complication in vivo should be required. This is due to critical factors such as the effects of the inflammation, edema, soft tissue healing, and scar formation could not be evaluated and would likely affect the outcomes of these procedures. Number 3, indication for tenodesis is for stabilization procedures. Example in A, triple tenodesis of genu recurvatum. There are two types of genu recurvatum. One with bone deformity, which responds well to osteotomy, and one with posterior soft tissue laxity with secondary bone changes. An operation for this type of genu recurvatum in post-poliomyelitic is described via this illustration. This figure shows the Perry, O'Brien and Hodgson operation for genu recurvatum. The A illustrates the origin of the medial head of gastrocnemius has been released, leaving a proximal strap. A broad flap of the posterior capsule is released for future advancement. B. The semitendinosus and gracilis tendons are divided at musculotendinous junction. Each is passed through a tunnel in tibia, then across exterior of the joint, and then through a tunnel in the femur. The flap of the posterior capsule is advanced and sutured snugly with the knee flexed around 20 degrees. The C shows the cross straps are made with biceps femoris and iliotibial band. For B, ankle joint weakness due to peroneal tendon weakness. In the presence of chronic peroneal tendon subluxation or dislocation, chronic ankle instability or hindfoot varus deformity associated with retrofibular pain and swelling, a doctor should be alert for possibility of tear in the peroneal tendons and indication for surgical intervention. Example in peroneus brevis tendon tenodesis for stabilization procedure. And lastly, regarding other indication of tenodesis. A. In distal peroneus longus tendinitis associated with os peroneum. The procedure include debridement of the peroneus longus tendon, removal of os peroneum, tenodesis of peroneus longus to peroneus brevis. As illustrated, the green circle shows the os perineum, osperonium. B. Proximal rupture of bisect tendon. The procedure involves proximal end of tendon detached from glenoid. End of tendon is rolled and sutured or not. Knot is inserted in the cortex of humerus infloor of the bicipital groove. As illustrated, the proximal rupture of the bisect tendon. Yay! We have reached the end of our video. I hope you have learned something from this video. See you again in the next video. Take care and bye.